Okay, Dr. Minu. Now we have 4 stations, and I already told you how we are going to do it. It's a mini mock. So let me set timer for you. So 2 minutes timer. I'm going to show you the first station.
Okay.
So this is the first station. And your 2 minutes starting now.
I can't see the timer. Can I see the timer?
Oh, sorry. I don't know how to fix the timer here,
Okay,
but
okay.
it will ring. You will know.
Okay. Any more slides for
No,
this question?
this is the only slide.
Okay.
Okay, you can start.
Okay, I'm Dr. Minu. I have read my station and I'm ready for discussion.
Okay, doctor, as you can see that you receive a patient and she's 27 plus weeks, primary gravida, 20 transfusion, and she's symptomatic, right? She came with a complaint. So I want to know that what is the information that you need uh, from your previous shift, right? Your ST5 that you are receiving endorsement, and what you are going, how you are going to manage her in your shift, because she's going to be with you at night.
Okay. So the situation here is a primary gravida patient with decreased fetal movements, and in the background, she's a twin pregnancy, 27 plus 6 with twin transfusion syndrome. So I will make my recommendation based on further assessment from information gathering, that is from her history, examination and assessment. So information from history, I want since when is she having the decreased fetal movements, and is it associated with any bleeding, any leaking, any fever, and in her, and regarding her pregnancy, was it a spontaneous pregnancy or an artificial IVF pregnancy, and any complications during pregnancy like any hypertension, diabetes, or bleeding during the pregnancy? Was she booked under the consultant-led unit? Was her hemoglobin optimized during the pregnancy? And did she have her scans from 16 weeks onwards as per schedule? When was the TTTS found out? That is which scan, and what was the stage of the TTTS also? I would like to know. And also, apart from that, any other medical history, any surgical history, any allergies, blood group, any reservation for blood transfusion, how is her support, mental health, and family history of any concern. Then from the examination, I would like to see her temperature, pulse, BP, and also look at the abdomen, whether it is soft, any tenderness, and also if there is any bleeding or leaking, I would do a perspective examination. I would ask for a hemoglobin, complete blood count, and connect her to the dual CTG machine to see if both the babies are doing fine, and also would like to do an ultrasound scan to see how the first twin is, what is the presentation,
Mm,
and also the well-being of both the babies.
mm.
This much information I would like to have. And regarding management, shall I proceed? Yeah.
Yes, please, the management.
Yeah, okay. Regarding management, I would like to first of all counsel her regarding the situation, like based on the stage of TTTS. I would like to tell her that you need to admit her now, and because it is a evening time, we will need to monitor her with the dual CTG for both the babies, and there will be a multidisciplinary team of management in which will involve my consultant, the neonatologist, the
Mhm,
anesthetist, and also the blood bank. And I will need to arrange her blood for blood and group and save, and
mhm,
all the complete blood count. And also I would start her on antenatal steroids because we might need to deliver her soon, like 12 betamethasone 12 milligram 24 hours for two doses, or dexamethasone 6 milligram 12 hourly 4 doses.
mm,
And if at all we can also consider, after informing my consultant, we might need to give her magnesium sulfate for neuroprotection also. I would do an immediate consultation with the neonatologist and see if there are two beds available in the NICU, whether all the facilities are available for neonatal care there, if in
mm.
case any emergency CS is required. And also,
So, what are the things
yeah,
that you will observe?
I will observe her pulse, temperature, BP, and also both the heart sounds of the babies with the
Are you
CTG.
going to do continuous CTG?
Continuous CTG monitoring will be done for both the babies.
Okay. And what
And
else?
if there is any pathological CTG, then we will be arranging for an emergency cesarean section for the patient,
Okay. Is there
with
anything
after informing
else
consult.
you will observe?
Mm, um,
Any sign and symptoms that you will observe?
any pain, abdomen, any bleeding,
Mm-hmm. So,
and
yes.
any leaking. Yeah.
Okay. And what about, are you going to give her kick count chart or no? Together with the
Yes.
CTG?
Yes. I will ask
Okay.
her to do the fetal moment count also.
Okay. So this is what you will do during your shift. Then, what is your arrangement for for the morning?
For the morning, I would like to arrange for a fetal medicine specialist review for her,
Mm-hmm.
and depending upon the stage of the TTTS, we might need to arrange for the that is the treatment for the TTTS, that is fetoscopic laser ablation of the communicating channels. That will be done by the fetal medicine expert, and if that is successful, then we and also we may have to do the ductus venosus Doppler also for the twins if there is any Doppler abnormality happening.
Mm-hmm.
Um, um, and if the laser ablation is successful, then we have to daily do the umbilical artery Doppler and ductus venosus Doppler, and also monitor for the taps for the patient, and she could be taken till 32 weeks at least, and then plan her delivery,
Okay. So
cesarean.
if her Doppler shows that she need to be delivered by cesarean section, what are the things you will take care? What you will endorse to your next shift that, you know?
The hemoglobin should be optimized,
Okay.
and it has to be because the neonatology should be
Mm-hmm.
informed and make sure that beds are available. Consultant should also be informed, and uh, WHO checklist should be maintained, aseptic precautions, antibiotic prophylaxis,
Mm-hmm.
and also make sure make sure where the placenta is, uh, and active management once babies are delivered, and um, active management of third stage of labor,
Mm-hmm.
and um, and, uh, watch out for PPH, and because that is a possibility for twins,
Mm-hmm.
so we should be ready for managing PPH. Like we will keep everything ready to manage a
Mm-hmm.
PPH.
Okay.
And
So whenever you tell that you have to do this thing, so you need to tell me what is the rationale of doing it. What's the purpose of? I mean, you need to justify. So, okay, as you said, you want to do the active management third stage, and because she has high risk of bleeding because of the twins. Yes, that's true.
yes,
You justified it. Anything else? 1.5 minutes left.
um,
We can move. No problem.
okay, okay.
Okay, now you have 2 minutes, and I'm giving you 2 minutes. You can start writing your bullet points.
Okay.
Okay, you can start your station. It's 10 minutes now, starting.
Hello, I'm Dr. Minu.
Hello.
I'm the specialty trainee in the clinic today. May I confirm your name and age, please?
Yes, doctor. I'm Linda Johns, and I'm 25 years old.
Okay, Linda, I understand that you are pregnant. You are 20 weeks now, and you had the scans done today, and you are here to
Yes.
discuss the reports. Is that so?
Yes, doctor, that is true actually.
Okay. Has anybody discussed the reports with you? Are you aware of the
Um,
report?
mm, yes, actually, I'm aware of the reports, and actually I came here to discuss with you about um how can I terminate this pregnancy, because I'm a student also, and I'm working, um and I have seen one of my friend who is having a child like this with inverted feet, both of them, and the child was not able to needed assistance to walk, you know. I cannot really take care of a disabled child, um, not now, you know. So I really cannot.
Okay, so I will address all your concerns, Linda, and we can come to a management plan. Before that, can I ask a few questions and then
Yes.
we can discuss it? Is it okay?
Yes, doctor, you can ask.
Okay, so Linda, I can see that this is your first pregnancy, and
Yes.
is it a planned one?
Um, yes, it's a planned one.
Okay.
And even I took the folic acid, and me
Mhm.
and my husband was actually very happy. Um, but since I know this thing, I'm very upset.
Okay, we will discuss about that. Any problems so far in pregnancy? Any bleeding? Any
Uh,
issues so far?
no, no bleeding, but I had like um, uh, a lot of nausea and vomiting in the beginning, but that is
Okay.
settled down after 3 months.
Okay, all right. And do you have any other medical conditions for which you're
No,
seeing GP?
no
Okay.
doctor.
And any family history of concern, like any children, any genetic problems with the children, anything like that?
No, as far as I know, no.
Okay. And your partner is fit and well also?
Yes, doctor.
Okay. And please don't mind me asking, do you smoke?
Yeah, I used to smoke, but I stopped smoking like 6 months back.
Okay, that's good. And may I any family history of sorry any uh, uh, any how is your support at home?
Yeah, my husband is very supportive. He is.
All right. Okay. Yes. So, Linda, now coming to your reports, Linda. So, I can see that the ultrasound is showing the bilateral talipus that is you just described. So, may I know how what you understand by that condition? Can you tell me?
Yes, doctor. What I think what I understand is what my doctor told me, that both of the feet of the
Mhm,
baby are turned inward.
mhm,
Yeah,
mhm.
and
Yeah.
and so I tried to Google it out, and I tried to, you know, to see what how the baby looks like.
Yeah.
So that's why I'm more worried.
Mhm. Okay, so let me tell you. So this condition is happens when the fetus, as you said, inwards and turned in, which we call it as a wonky feet. It happens when the ankle, there is a tendon there, it is called as Achilles tendon. When it is
Mhm.
shortened, this could happen. And but you see, there are different options available, like when after baby is born, there are certain options by which can I tell you all the options, and after that you can decide about it, so that you can have an informed decision. Will that be okay?
Oh, doctor, so you were telling me about why this tendon. Um,
Okay.
I mean, is it like something
Yeah.
common, or is there something?
Yeah,
Um,
it is. Yeah.
what is the cause of it? I mean, what's why my baby got it?
It's a very rare condition, and we may not know why this has happening. Sometimes can happen in isolation, but
Hmm.
sometimes it could be associated with certain genetic problems also. So
Oh.
what we can do is that we can have a I will give you an appointment with the specialist doctor, that is the fetal
Mhm.
medicine specialist. He will do a detailed scan for you, and
Oh.
if there is any associated abnormalities, then he might offer a test like the needle test to see if
Hmm.
there is any associated problems with the baby. If there is
Okay.
no associated problems, then it is this condition is a very correctable condition, in which
Mhm.
the once after baby is born, baby will be seen by the bone doctor and the pediatric, the baby specialist doctor, and these feet can be they try to stretch the feet and put it into a come to a correct position, and the method is like after correcting into the correct position, they put a cast, and baby
Mm-hmm.
will have to wear the cast for around 5 weeks at a time, and like 4 or 5 casts may be put, and after that usually the feet will correct after that. If
Oh.
that is not coming, then a small surgery can be done to correct
Mm-hmm.
the problem also. And after that, baby will be given certain boots to wear. Baby can wear it first of all throughout the day, and after some time only at night. So by the time, usually what we see is that by the time baby starts to walk and run, they will be walking like any other normal kids only, because this
Mm.
problem is completely correctable problem. And
So,
what
doctor,
do you
is
think?
this
Yeah.
a guarantee that it will be corrected completely?
You most of the time it will be corrected completely, and there won't be any problem. But that needs to be the physiotherapy might need to be continued for some time also, because if we do not take care of it, this can sometimes recur back. So
Mm.
most of the time, this is a very correctable condition, and so I will give you an appointment with the fetal medicine specialist, and he can discuss you in a better way. And also, the chances of recurrence is also very rare in the next pregnancy. And once,
Doctor, still,
yeah.
if I want termination of pregnancy, do I still have time or is it very late?
According to the UK laws, the termination is allowed till 24 weeks only,
Mm.
and that needs there has to be a particular indication for that also. And
Mm.
usually for correctable conditions, we do not recommend a termination. But if you still insist, then we can have a discussion with our consultant, and then came to a management plan. So yeah, so I can connect you to the support groups like steps, in which parents who have children like this, you can talk to them, and you can know in a better way also. And there are counseling sessions also, if you wish I can give
So,
you.
doctor,
Yeah.
is it possible, like at this age, because I'm already 20 weeks, if I'll do termination after 1 week, for example,
Yeah.
or 2 weeks, is it safe?
No, as the pregnancy advances, the safety of doing a termination of pregnancy the risks are also more. It is almost like a small delivery, in which we will have to induce you with the medication, and sometimes if after 22 weeks baby could be born alive also. In that case, we may have to give an injection to stop baby's heart, and then give you in medicines to induce labor, so that it is like a small delivery. And the complications are also more if you go ahead as the pregnancy advances. So the risks will be more, like more chance of bleeding, more chance of
Mm.
injury to the womb and neck of the womb, like that. So
So there will
uh,
be pain also?
there will be pain also.
Mhm.
Yes, during pain, and the womb will be contracting and delivering the baby. It's like a small delivery after 20 weeks.
So I will be given painkiller?
Yeah, you will be given painkiller at that time, if
Mm.
that is your decision. But the decision will be once made by the consultant only.
Yeah, so next
So
time I need to see the consultant.
yes, if you still wish to go ahead with the termination, then I will give you an appointment with my consultant, and I will also document everything and give you all the information details, and give you next appointment with my consultant.
Okay, thank you very much. Just give me
Yeah.
like maybe I don't have to take all this time. So just give me like 1 minute only. I'll stop it and then we will uh, continue.
Okay.
Just 1 minute.
Yeah.
Okay, we can continue actually. So let's
Okay.
do the third case. So I'm giving you, this is the third case. You have 2 minutes. Oh, you can see, sorry, I'm sorry. So you have 2 minutes starting now. Okay, go on. Okay, you can start now.
Okay. Hello, I'm Dr. Minu. I'm the specialty trainee in the clinic today. May I confirm your name and age, please?
Yeah, doctor, I'm Tamara Johnson and I'm 30 years old.
How may I address you?
Tamara is fine.
Okay, Tamara, I understand that you are 12 weeks pregnant and you are here to discuss the reports of the test which you have just undergone. Is that so?
Yeah, that's true. And I'm a little bit
Okay.
surprised that my midwife sent me to you actually. Um,
Mhm.
and I'm fine, I don't have any problem.
Okay. So, has the report been discussed with you by anyone before?
No.
Okay. All right. So, I'll be discussing the same. And before
Mhm.
that, can I gather a few information? And after that, we can discuss and come to a plan. Will that be okay?
Yes, that it's okay.
Okay. So, Tamara, how has been the pregnancy so far? Any problems? Any nausea,
Yeah,
vomiting?
no vomiting, a little bit of nausea. Not a
Okay.
big deal, yes.
Okay. And you are taking folic acid?
Yes, I'm taking
Yeah.
it regularly even before pregnancy.
Okay. And your dating scan is done? It is normal?
Yes, doctor. Dating the
Okay.
scan, yeah, yes, it is done.
Oh, okay.
Yeah.
All right. And your periods are otherwise regular?
Yes, it was a little bit irregular, but because
Mhm.
I know from my scan that I'm 12 weeks.
Okay. Was it a planned pregnancy?
Yes, doctor, it was.
Okay. Okay.
It
Any
was a very,
treatment
very
taken?
much planned pregnancy. I was waiting for it.
Okay. Any treatment taken for the pregnancy?
No, actually,
Okay.
no. Mhm.
Mhm. And do you have any other medical problems for which you are seeing GP?
No, doctor, I don't have any
Okay.
problem.
Any allergies?
No,
Any surgeries in the past?
no, doctor.
Okay, you're 30, your smears are up to date.
Hmm.
Okay, and any family history of concern, any clots and any diabetes or anything in the family?
Yeah, my mother is diabetic on medication, and my father is hypertensive, also on medication, but they are both of them are doing well.
Okay, I'll make a note of that.
Mhm.
And please don't mind me asking, do you smoke?
Yes, I do. Since I started this pregnancy, I decreased a lot. Before I was like taking 10, 15 cigarettes per day. Now I'm reduced to 4 to 5 per day.
Okay. If you wish, I can connect you to the NHS Stop Smoking services also, because smoking is not very good for the pregnancy. Will that be okay for you?
Okay, I'll go for it.
Okay. Okay. Any, do you take alcohol?
Yes, on weekends.
Any drugs for recreation? Pardon me for asking.
Uh, yes, I was taking marijuana before this pregnancy, but I stopped.
Okay, okay, that's good that you stopped because it is not good for the pregnancy. And if you wish, we can connect you to the de-addiction centers as well. They can help you. Also, can I ask a few sensitive questions? It's a confidential discussion. Will that be okay?
Go on, doctor. It's okay.
Okay. And how long you are with your current partner?
Since 6 or 7 months, yes.
Okay. So before him, were you with someone else also?
Yeah, my partner was someone else. Yes, that's true.
Okay. And anytime you had any sexually shared infections in the past?
Yeah, like 2 years back, I had chlamydia infection, which was treated.
And it was completely treated at that
Yes,
time.
they tested me again for this.
Oh, all right. Okay. And are you well supported at home?
Yeah, my current partner, you mean? Yes, he
Yeah.
is fine.
Okay. And what do you do, Tamara? What do you do
Yeah,
for a living?
actually, I'm working as a private secretary in one of the firm, one of the
Okay.
company. Yes.
All right. Okay. All right. Now coming to the reports, Tamara.
Hmm.
So I have confirmed that this is your report with your
Hmm.
name and also the NHS number. I have some concerning news for you, Tamara.
Oh, okay.
Okay, so the one test which we did, that is we did do this for all pregnant women. It's a screening test, and it is called as the HIV test. It has come as positive, Tamara. I'm very sorry to say that.
HIV? Do you mean AIDS?
HIV, the test has come as positive, Tamara, and AIDS is a condition when we cannot when this gets into a complicated form, we call it as AIDS. Yes, you're right. That virus, it has come as positive.
So, doctor, from
um,
where it came? Um,
Yeah,
I
it
mean,
is a. I will tell you, Tamara, because this is a condition. It is transmitted by a virus, and it is a sexually shared infection. Okay, so because of the nature of the transmission, it is usually got from either sexual infection, or it could be also transmitted from the mother to the baby in utero also.
you
So.
mean my baby can get it?
Yes, if we do not treat it, that is a possibility.
Oh,
So, because of the nature of it, we might need to have your partners also tested. There is
mhm.
a partner notification system from our side, which we can do without breaching your confidentiality, or you can talk to your partners as well. It is very important to do that.
Okay.
Also, we need to test you for other sexually shared infections like syphilis, hepatitis B, C, and also gonorrhea and chlamydia also. And
Mhm.
Tamara, if there are very good treatment available for this condition, which we call it as a highly active retroviral therapy, it is safe. The drugs that we use, it is safe in pregnancy, and if you started early in pregnancy, then the chances that baby could get infected from the mother becomes very less. If you do not start it, the chances is around 25 of 100, but if we do start it, it will reduce to 1 in 100. Okay, am I clear so
Okay.
far?
Okay. So
Okay.
1 in 100 chance.
Yeah, yeah.
So if even if there's 1 in 100,
Mhm.
so if it happened, the baby needs to be treated also.
In that case, baby will need to be treated also. Baby will be seen by the baby doctor. Baby will be tested, and then we will see if baby needs to be treated. For the time being, your care will be in the consultant-led unit from now on, and
Mm-hmm.
it will be a multidisciplinary team with my consultant, the HIV specialist. We will involve the mental health specialist also and specialist nurse,
Mm-hmm.
and we will be doing certain preliminary tests like the liver function test, the complete blood count. We need to look at the viral load also, and
Mm-hmm.
also the immune cells, because this virus actually affects the immune system of our body and decreases the immune cells, so that
Mm-hmm.
any small infection can flare up. That is the
Oh.
main thing which happens with HIV. So we will do the viral load, and we will start you on the medications. If it is too much, then we have to start it straight away. If it is less, then we can start it by just before, but anytime it before 24 weeks we need to start the medications. And we will make sure that if you are going in for any invasive procedure, the viral load will be repeated, and also at 36 weeks, and also in every trimester we will do it, and at 36 weeks also. Now, the mode of delivery will depend upon the viral load at 36 weeks. If it is less than 50, then we can offer you a normal delivery. But if it is
Mm.
more than 50, then a cesarean, we will have to offer you cesarean section at that time. Am I clear so far?
Yes, doctor, but I know that AIDS is bad. And is there anything that can stop me, that can eradicate, that remove this virus from my blood?
By this treatment, it is possible that you this virus may not be transmitted to others. By this, when you take this treatment,
Mm-hmm.
the transmissibility of the virus from one person to another could be reduced. It could be really minimalized, but we may not be able to completely eradicate the virus from the body, and you need to be under surveillance lifetime, and you need to take the medications also even after pregnancy. Also, this medicine need to be taken lifelong, because it will even after pregnancy it can affect the other organ systems. So that is how it
Can I
goes.
breastfeed my child after delivery?
It is not recommended, Tamara. By breastfeeding, also the virus could be transmitted to the baby. So it is
Mm-hmm.
recommended that we do not breastfeed the baby.
Oh,
So I will give you all the information details in writing, and give you the inform my consultant and document everything,
mm.
and we'll get you in touch with the specialist doctor so that we can start the treatment right away.
Okay,
All right.
that's it. Yeah. So okay, good. So let's move to the fourth one, and your 2 minutes are starting now. Go on. Okay, you can start.
Hello, I'm Dr. Minu, one of the candidates for the examination. I have read the gynae list and I'm ready for the discussion.
Okay, good. As you can see, doctor, that there is a list of 4 patients. So you need to prioritize your list, which one should go first of all. The other thing is that what are the things that you need to check before they go for the surgery, and what are the risks and how you can minimize these risks.
All right. So in each case, I would go to the patient and I would take a detailed history
Mm-hmm.
and I would see if there is any medical comorbidities or surgical risks for the procedure. I will
Mm-hmm.
review the consent form and see all the risks, benefits, and alternatives have been discussed with her. I will
Mm-hmm.
go through the pre-anesthetic checkups also,
Mm-hmm.
and in all reproductive age groups, I will be doing the UPT and ruling out any pregnancy, and
Mm-hmm.
also rule out any medications that she is on,
Mm-hmm.
and look for any risk factors for DVT. And also, I would discuss the procedure with them, making sure that the enhanced recovery program is put and make up post-op management for each patient.
Mm-hmm.
So the first patient is a young patient, and
Mm-hmm.
she's for planned for diagnostic laparoscopy. The reason being chronic pelvic pain,
Mm-hmm.
and so here the risk factor here is one is BMI is 18, and second is she has chronic pelvic pain. So there could be endometriosis. So we are expecting adhesions here. So the on the consent form, I would like to tell her that sometimes in laparoscopy, we may not be able to find a cause. And if there is a cause which we are able to find, then we can do the ablative procedures or excision in that case. Also, the chances of bowel and bladder and blood vessel injury, I will tell with her. And sometimes some bowel injuries may not be able to detect, and it can happen later on also. I will discuss the other alternatives also. So here the intra risk is BMI 18 and adhesions. So the entry should be either an open entry or a Palmas entry is best for this patient.
Mm-hmm.
And the question is, what are you going to do if you find stage 1 endometriosis?
Mm-hmm.
So in stage 1 endometriosis, we can do either ablative procedures or excision of the endometriotic deposits.
Mm-hmm.
Now, going to the second case, she's 48 and she's posted for TAH with total abdominal hysterectomy with plus or minus bilateral salpingo-oophorectomy, the indication being a 15 centimeter fibroid. So, preoperatively, I would like to rule out any surgical risk factors and also medical comorbidities. BMI is 38. So, that is the risk factor for her. I will make sure that the compression stockings are put, and also look at the consent, whether any other alternative options have been discussed with her. Any pre-op GnRH has been given to reduce the size of the fibroid, and
Mm-hmm.
also what about the incision, whether it's going to be, I will tell her that it will depend upon the size of the fibroid during the procedure. It could be an up and down cut or a phalansteal incision, and this has to be done in the presence, if it's a presence of this senior consultant, because of the technical problems with the high BMI intraoperatively. So and meticulous hemostasis has to be achieved, and we can put maybe drains needs to be put or interrupted sutures, because to reduce the chance of infection. In all the cases, WHO checklist, aseptic precautions, and antibiotic prophylaxis will be taken care of. And postoperatively, we need to assess her VT prophylaxis based on her BMI and renal function. And
So what
also,
about if you give her midline incision, for example,
yeah,
then what precaution that you need?
yeah. Yeah, in if it is a midline precaution, then midline incision,
Mm,
then the postoperatively she might need binders, and also the rectus sheet should be closed with loop proline, and also interrupted sutures can be put for the skin incision. And post-operatively abdominal binders, and also elastic compression stockings, and early mobilization and hydration should be taken care of. And
Okay.
regarding the removal of the ovaries, if there is a family history or if the scan is showing any pathology to the ovaries, then we can decide on removing the ovaries. Otherwise, and also if we should take her wish also, whether otherwise ovaries should be preserved, because till the age of menopause, the otherwise we may have to give her hormone replacement therapy. Again, that would be a risk factor with BMI 38. So the third patient is evacuation of molar pregnancy, and it's a 12-week uterus. She's Rh negative. So we need to make sure that the enough blood is arranged pre-op, and intraoperatively ultrasound guided scan has to be done by a senior consultant, because there could be bleeding could be expected, and also we need to counsel her regarding the chance of heavy bleeding, and also the need to send the products for histopathology, need to register her to the molar registry center, and also give her anti-D because she's Rh negative, and we should advise her regarding the follow-up of molar pregnancy, the importance of contraception during the follow-up period, and need to stick to the follow-up plan because of the chances of gestational trophoblastic neoplasia, depending upon the whether it is complete mole or incomplete mole. And the question here is what to do if heavy bleeding occurs. So if there is heavy bleeding, we need to speed up the evacuation as quickly as possible, and once the evacuation is complete, then we can start her on pitocin, oxytocin infusions, because otherwise there is a chance of tumor embolization. Next is the fourth patient is planned for 30-year-old, planned for laparoscopic cystectomy, 6 centimeters. I would like to look at the scans also, whether there is any complex nature of the cyst, any M features, malignant features are there for the cyst. CM identifies only 12. And here the risk factor would be that she's a previous cesarean section, and also there could be adhesions, so we could do an open entry for this patient or a Palmer's technique. And while doing while taking consent, we need to tell her that if we will try to remove the cyst early, but there is a possibility that if it is too much adherent or if there is bleeding, ovary could also be removed, that likewise the consent has to be taken. And then we should make sure that these contents are not spilled in a remove the cyst in a bag without spillage, and remove it through the umbilical port. That is the
So
best
what you're
method.
afraid of? Why you want to remove cyst in a bag, retrieval bag?
Because if it is a dermoid cyst, then the chances of peritonitis is there, and if it is a malignant cyst, then the chances of upstaging the disease because of peritoneal metastasis can happen. So that is why we need to remove it in a bag. But then my priority of the list would be, first I would be posting the molar evacuation first, then the diagnostic laparoscopy patient, because she can be discharged the same day or the next day. And third will be the laparoscopic cystectomy, and the fourth will be the TH, total abdominal hysterectomy patient, because she will require an inpatient management.
Yeah.
So that would be the list.
So doctor, what do you think that this fourth case, don't you like to see that? Can we do like conservative management for her?
Yes, I would like to look at the scans also and see if it is a simple cyst, and CA125 is 12 and she's 30. So all the tumor markers, other tumor markers are negative, and the RMA score is less than 200, then we can go in for a conservative management in that case.
Okay. So you like to review the
Yes, I would like to review and consent form. Yes.
Yeah. Okay. Anything else you want to add? You have like 20 seconds more. Okay, so we can. So I'll give you like your individual assessment feedback in each case, what you have done, and then whatever the model answer that I wrote, they were you give me like very nice few points that I might add to my model answer. So I like it. So let's start with the first one. So it was twin to twin, but you don't know much about it because information is not enough. So of course you like to know more, and you are receiving her in labor ward already. It means that looks like that she's already admitted to the labor ward, and you are just receiving it from the previous shift.
Okay.
So, and you are in the evening shift, so the patient is going to stay with you at night. So you
Okay.
need to like in your 2 minutes, you need to create that scenario in your mind, that what are things that you need to do at that night, and then what you are going to arrange early morning. So these are the things that should be in your mind, that what you should look at her chart, ask the patient, or take endorsement from the previous shift. What are things that you will observe at night? What are things that you are worried of, and you will take care, and how you will arrange in the morning. Okay, so yes, you did it right actually, and you started with the uh, yeah, you took the information correctly. You
Yeah.
know, you ask all about her. You want to review the file. You want to look at when she received her last treatment, when the last scan was done, how was her Doppler, and what is the plan written by her by the team of the fetal maternal, and if there's any treatments done or not. Um, so all the I think you have asked, you gathered information, and then y- you should ask from the. Did you ask the your previous shift that um, the consultant is informed or not? So you want to know from your previous shift that for her admission, if the neonatologist and consultant are on board and they are informed or not. Although you said that I will inform my consultant, I'll inform the neonatologist, make sure the neonatologist knows, which is fine also. But you can ask your previous shift also, like you are taking endorsement from.
Okay.
And you are right that you will do the admission CTG, and you will do the CBC and the group and save. Um, did you say you will send group and save, or you didn't say? Uh,
Yeah, I said. I
you,
said.
so you said, okay, that's good. And then you said fetal well-being. So you like to do bedside scan for and biophysical profile or something?
Yeah, I thought I would make
Hmm.
sure about the
Yeah.
presentations and yeah,
Hmm. So the
placenta.
fetal presentation, the placenta location, and you said fetal well-being, which
Yeah.
means a biophysical profile can be done, of course, by an obstetrician. There is no problem. If you have a bedside scan, why not? And then continuous CTG. She needs continuous CTG. I'm
Yeah.
just,
Yes. No.
she's not contracting, right?
Decrease. Oh, okay. 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 If she's appreciating fetal movements, then that would not be required. Okay.
So
Okay.
you can just give her like kick count chart. And if
Okay.
any time you will keep on observing her, and if any time she complain of decreased fetal movement, or she start to contract, she start to leak, or she start to bleed, you will start
All
the
right.
CTG.
Okay.
But only decreased fetal movement, and
Mhm.
you have done everything CTG, and you make sure that babies are, you did even fetal well-being, you did bedside scan. So once admission CTG, and then you can check like on and off fetal heart by Doppler, but
Okay.
doing continuous CTG, I don't think so, unless you start to contract or have any other complication. So yes, you are right. Multidisciplinary team you mentioned, which is a very good thing, that you need to mention multidisciplinary team needs to be involved. And you talked about the steroid, and then you said magnesium sulfate after discussion with your consultant. If you will only say I'll give magnesium sulfate without talking to your consultant, then it will be wrong. Then yes, you are after agreement with your consultant, there is a safety point. And then you talked about observing vital signs, of course, and bleeding and leaking and contractions and pain. all these things needs to be observed until um, like next day, when you will refer the patient to the fetal-maternal unit, and then they will do the scan again, and they will do the Doppler, and accordingly, whatever the situation of the baby, they will decide what to do. Don't go in too much detail about ductus venosus and all of these things.
Okay.
Just you have to say, and you have to stop at some point, that I'll refer her to the fetal-maternal unit. They will do the Dopplers, they'll do the ultrasound scan, and they will decide what to do. If they decide cesarean section, come back, because you are in the labor ward. You are not concerned what they will do. You will just say that if they decide for cesarean section after doing ultrasound and Doppler scan, then what you need to do, how you need to prepare yourself, because I want to know what you will do, not what they will do. Yeah, but you have to say a little bit. Once you will refer, they will do ultrasound, they will do Doppler scan, and if they decide for cesarean section, so the patient is going to come back to the labor ward for cesarean section. Then, because a little bit I prompted you at that point, and then you told me everything, that you have to make sure that the neonatologists are there, because it's a twin. So 2 sets are available, and the WHO checklist, antibiotic prophylaxis, because she's high risk for bleeding. So active management of 3rd stage. And whenever you say something, generally speaking, in every station, just try to justify it, whatever you say. For example, if you will say active management of 3rd stage, then you need to justify yourself. Yeah, it will be a good practice if you will only add this a little bit of justification. All the other things you said is all right, and most of the things you said. So let me see what I wrote in my model answer. Yeah. Yeah, so you gather information from the case notes, from the previous shift, and from the patient. You need to know that this is a spontaneous pregnancy or not, and when twin to twin transfusion was diagnosed. So it's a twin, maybe it's an IVF pregnancy, right?
Yeah. Okay.
Yeah, so twin to twin transfusions diagnosed and what stage. You said you talked about the stage and everything. You want to know how was the Doppler last time, if she received laser treatment, how many times she received laser treatment was done before, and any Doppler scan was the last. What was the time of the last treatment when the last scan was done? Or you're collecting information and the plan written in her notes from fetal maternal unit. So consultant, it's a safety point that consultant is informed or not, and then how the babies are doing, if CTG started or not. If not, you will start the CTG. You can ask your colleague that if NICU beds are available when you admitted the patient, have a talk to the neonatologist, and they agree for them, they are ready for them. If so, you will observe contractions, leaking, bleeding. And you talked about bedside scan for Laker, and CTG on and off you can do, or once admission CTG, or then checking the heart heart rate by. Actually, this is a good idea, just to do admission CTG and then check fetal heart, give her kick count chart, and then check fetal heart every now and then by Doppler. There is nothing wrong in it, actually. And informing theater that anytime you might need to take this patient for cesarean section. A pediatrician's consultant, if not informed yet. You said about steroid, you said about preterm cesarean section, um, that as you might go for the preterm cesarean section. Okay, in the morning, refer to the fetal maternal unit. They will do the Dopplers. They will see if they decide for cesarean section. Then you can start magnesium sulfate and arrange for cesarean section. So you will arrange for cesarean section. So your 2 pediatrician, 2 sets of clamps, counsel her that the babies will need NICU, of course, after delivery, and she can breastfeed or can pump, and will refer to the breast specialist nurse, because preterm twins might have some problem for the breastfeeding. So you can talk about it. There's something else you said which I like it. Yeah, you also added um, the other things, like, you know what you said, you said that the consultant should be there because it is going to be a difficult stage. So senior consultant or the consultant should be the one present around. You talk about WHO checklist and antibiotic prophylaxis. You talk about active management of third stage of labor, which is all good. So it's kind of like it's okay. It's a passing station. And let's move to the second one. Yeah. So it's a bilateral TALIPS, and she was really insisting for termination of pregnancy. So you started like information gathering from her. Um, yeah. So here you, in information gathering, you ask all the good things. And I like, what I like that you didn't ask about pap smear and menstrual, how was her menstruation, is regular or not. So I'm happy that you didn't ask here because it's not part of the targeted history. No need to talk about the Achilles tendon, you know.
Okay.
And she doesn't, she will not understand what is that tendon, and but you can explain to her that it can happen. I wrote it, I mean, some incidents that it can happen in some of the babies, and most of the babies do well after some adjustment. They might just need boots, or some of them might need some surgical correction, and later on they will be wearing some correction boots, and but most of them are leading their independent life. um, yeah, so usually we don't recommend termination of pregnancy on if it is isolated and if it's the only problem that the baby have. But if you really make up your mind, let me tell you more about it, and then I will let you talk to my consultant. And if you're and after all the discussion, if this is your decision, then I respect your decision, and I will let you talk to my consultant. You can decide with him. But let me tell you that you have to tell her about the termination of pregnancy because I prompted you. She was
Yeah.
insisting about termination pregnancy. Tell her that at that
Okay.
stage, because you are 20 weeks now, if you will do it
Mm,
after a week or two, then what
mm,
can happen? Like you might need to give her the injection to stop the heart so the baby will not born alive. The other thing that you might have pain, like a delivery pain, so you will need a painkiller. And the other thing is there's a high risk of bleeding of like termination at this stage, and you mentioned about some of the risk. And then yeah, and even for the next pregnancy, you said that the risk of recurrence is like is not more is minimal actually, and it's not above the baseline risk, background risk, because there's a background risk for every pregnancy. So and you even talk that it can be isolated. It can come with genetic problems. So I'm going to refer you the multidisciplinary team you mentioned, who are going to do what? They will do the detailed scan, and they might need to do a needle test because sometimes it come with chromosomal problems. And after confirming that there is no chromosomal problem and there is no other defect together with this problem, then you are going to follow up. We are going to follow up. Um, and because sometimes, this baby needs follow up. You know why? Because sometimes it gets corrected like spontaneously. If it's a little bit of a defect, with passage of time, it might become like fine. So she need follow-up ultrasound scans. And there's one more thing that after you can say that I will let you talk to the not only the neonatologist but the orthopedic surgeon, the surgeon who the bone doctor who will the surgeon of uh, who might, because your baby might need like correction. So he will tell you in detail that how these babies are doing, and I will give you information leaflet and all these things you said. um And then for the causes, you said that it might be after I prompt you, you said that it can be isolated or related with some genetic problems, you said. And then when I insist that if I want termination, then is it safe? So you could have said by yourself, but because if although I prompted, and I know that you know that, but if the examiner is prompting a candidate a lot, I didn't prompt you a lot, but it's not a very good impression if there's a lot of prompts. So it should go in a flow. So, but you said most of the things, and it's a passing station for you. Okay, let me see what I have written in my model answer. But although it's a passing station, but I have to tell you a few points that you can do it like 80%, 90%, 100%. Okay. So the baby has bilateral fetal talibus, and she wants termination of pregnancy, so she needs to be counseled. So these two things are clear. Why this bar is coming? Oh, okay, now it is better. So after introduction and confirming the name, and you ask her about the agenda. You ask her actually that if she knows, or is it a kind of breaking bad news? So you were careful and you asked her. So she knew it. She knew. So briefly tell her what information you have, and if she has any other concern that she need to discuss. So you ask her about her agenda. So you took targeted history about her current situation. How is the fetal movement, any pain, bleeding, leaking, how was the beginning of pregnancy, planned or unplanned, folic acid or not, Down's syndrome screening is done, and blood workup and urine workup is done. And I think you asked about the ultrasound scan, dating scan, and she's 20 weeks. So you ask about, yes, and this is how she came to know about the fetal talus, because she has done her scan. Anyway, uh, so you ask her also that if there is any problem during the pregnancy. She said there was no problem. You ask about medications, allergies, about her health, any family history of babies with defects, social history, smoking, alcohol, drugs for fun. And if you are asking this question to every pregnant lady, and what's her blood group, if she has any reservation for blood transfusion, all these things needs to be asked from all pregnant patients. So she's primary, so there is no obstetric history. So counsel her regarding your knowledge of talipus. You can tell her that if you don't remember the incident, it's okay. This is not going to fail you. But it's okay. If you remember, you can say. You said that it's a rare condition. So it happens 1 in 1,000 babies. The causes can be, maybe there's some pressure due to the shape of the uterus, maybe the baby is sitting, or due to less water around the baby. It can affect one or both feet, but the cause can be unknown. There might be, as you said, genetic factors involved. Like there's 3 to 4 in 100 chance that it might recur. Oh, there is a recurrence. I forgot about it. I'm writing it, of course, from a source. So 3 to 4 in 100 chance. If you don't remember, I mean, no one's going to uh, give you negative marks for not telling this. It's okay. It might be associated with other structural defects, like problem with the spine or the joint problems. So you said that you are referring her to, I'm referring you to specialized doctor called fetal maternal specialist. They will do detailed scan and will tell you clearly about your options. Needle, you told her about needle test for chromosomal problems. If she insists for termination, and this is her right, she can do it up to 24 weeks. But is it after 21 weeks or 22 weeks that she will need KCL?
Yeah, 22, I mean like 21 plus 6, I think 22.
21 plus 6. After 21, it means
22,
starting
after
from
22.
22.
Yeah,
Starting from 22 plus 0, right?
22 plus 0, yes.
And at We need to give her an injection to baby's heart, so she will not deliver, the baby will not deliver alive. And if she decide to continue, and if it's an isolated defect, then tell her that it might be a mild problem and she might not need any surgery, and if it needed, it can be corrected surgically after delivery. So she need multidisciplinary, like team of specialist doctor, like baby surgeon, bone specialist, follow-up scans. And I told you the reason why we need to do, because you need to justify everything. She can deliver vaginally and spontaneously at term, should be in an obstetric unit, so that, because there might be need of treatment after delivery, so it's better deliver in a hospital. And the same thing, patient information leaflets, give her support groups also, because she should, she knows only her friend whose baby was not able to walk, but there are other people around the world that their babies are able to do very well, and I think it will help her if you will give her support group contacts. Yeah, and offer
Yes.
next appointment with the consultant. So let me see what you have done with the third case. Um, what was it? HIV?
HIV.
Hmm. So you talked about, here you ask about pap smear. So here there is need of asking about pap smear, asking about sexual history, partners, all these things needs to be asked. Did you ask about if she's practicing safe sex practices? Yeah, you
No.
missed that, right? About this.
No.
So, okay, this is the thing which I wrote here. You ask about smoking, um, you ask about partner, since how long, so that you know her high risk history, as history of
Yeah.
STI. Um, and all the things you told her, like if you start treatment, it will be like 1 in 100, it will reduce the need of multidisciplinary team, LFT, CBC, viral load, immune cell, CD4. You said in every trimester at 36 weeks, what should be the mode of delivery if it is like less than 50 count and more than 50. So you told her cesarean, there is a chance that you will go for cesarean section, and there will be no breastfeeding. Either you deliver vaginally, or you're delivering by cesarean section. And then you talked about what are things. So yes, so the only thing which I noticed, that you didn't ask about the safe practice, and you ask about testing other STDs and informing the partner, and all the nice things you said. But let's see what I have written. Um, yes. So it's a breaking bad news. It is good that you didn't offer her that, let me call someone, a nurse with you to, so because it's a kind of confidentiality, you should not be calling anyone. So you will just follow the steps of breaking bad news apart from this. So
Okay.
um, you ask about targeted history. Like, she was very excited and happy about her pregnancy. She didn't know. Um, but you ask her initially. I like to ask the patient before giving her bad news. So you follow what I like, actually. You ask the history first, then you break the bad news, which is a good idea. So until 12 weeks, you ask her what happened, how is nausea, vomiting, pain, bleeding, is this pregnancy planned or not, if she is on folic acid still or not. Any health problem, medications, allergies, blood group, objection, reservation to blood transfusion, social history, which is important in this case, smoking, alcohol, drugs for fun, STI, support, occupation, if how are things at home, current partner, since how long, if she's practicing safe sex, condoms, her family history, blood workup and dating scan done or not. Ask her any history of blood transfusion. You didn't ask her about history of blood transfusion, yeah?
No.
Yes,
No. No.
because there are other means of transmission also. And if
No.
she was sharing the needles,
Okay.
sharing of needles,
Noodles.
because I'm making all my model answers by myself without looking at others. So I keep on adding things, whatever I remember. So just mention to her that you have a difficult news for her, and then tell her straight after that, after confirming, you confirm name and NHS number, which is good. It says that you're suffering from a viral infection called HIV. She knows about HIV and she said that, but you have to differentiate. You tell her that you have a virus, but you don't have a disease called AIDS. But this virus, if it is not treated, it might
Become.
eventually become
Okay.
AIDS, which has, yes, complications. Um, but now because it's still a virus and we have to do other tests, and then you talk about all these things. I'm sorry to be the nice words bearer of this news. Do you like to continue the consultation? Then you start your consultation. So be a little bit more empathic. And then you talked about multidisciplinary team, referring to HIV specialist counselors. This is a very tricky thing. Some people are really becoming very, very empathic to the patient, and they are lost. They don't say all these things which carries points, marks.
Okay. Mm.
So be empathic to an extent. So there's limitation. So whether it needs to be followed up in consultant-led unit. Yeah. So all the multidisciplinary team needs to be involved. She needs to be followed up in consultant-led. Talk to her about rest of the pregnancy. All like whenever you are talking about a pregnancy, for example, from the beginning of pregnancy until that particular gestation, ask her history, and then from that particular gestation onward, management starts, and then
Okay.
divide it into second, third trimester. Always stop at 36 weeks, which you did, because you have to decide, you have to plan the delivery at that time, place of delivery, time of delivery, mode of delivery, all needs to be discussed. You talked about CD4 count, frequency of it, viral load, and starting heart. Even you talked about STI screening, LFT monitoring. Uh, I think some of the
Yeah.
medication can give a patient
Uh,
diabetes. So
GDM. Ma'am, you said about her family history of diabetes, but I
Mhm.
forgot. You said
Yeah,
family
but
history of diabetes.
there's some medication. One of them, one
Yeah.
antiretroviral treatment, uh,
Okay.
which is
Okay.
can be the cause of high blood sugar. So
Okay.
it is written in the guideline that GDM
Mm.
screening needs to be done if the patient is on
Mm.
antiretroviral
Yes,
medication.
yes, yes. Just given.
And then repeat test 36 weeks, decide about the mode of delivery. Like you said, less than 50 or whatever, vaginally can be done. And if rupture of membrane anytime before delivery time, then she
Mm.
needs to be induced as soon as possible. You can add it.
Mm.
Even if you don't add it, it's not a very big deal. No breastfeeding. All these measures reduces the risk of transmission, as you said, to less than 1 in 100. Encourage her to talk to her husband by herself, and if she said that I don't want to talk, you have to say that then we will need to talk to him and inform him, because he has a right to know. So it is better that you inform him by
Okay.
yourself, because he needs to be tested anyway, so he will know. So use of condoms, and talk about contraception after delivery with condoms. Need of
Okay.
early pap smear, yearly pap smear. Did you say
Yeah.
that?
No, no.
Yeah.
I thought about that, but then I
No, you
forgot.
didn't
In
have
the
the
end, I
time
forgot.
actually. Talk about the need of neonatal follow-up, of course, patient information leaflet, support group follow-up. There are a lot of things to talk in this station actually. It's not a very it's not a very difficult, because there is a guideline and everything is there in the guideline, but there are many things to tell the patient, a lot of things in that 10 minutes. But you managed, you finished everything on time. It's a passing station for you. Okay, let's go to the fourth station, gynae list. Just give me a second, please. Okay, so this gynae list, you actually were fine. I like it because I'm telling all my students, whoever is doing this mini mock with me, that um, because for all the cases, you have to say the similar things. You are not going to finish on time. It is better to compile the things which is general for all the cases, like you did. You talked about the you will check if the consent is there, if the consent is valid, and if anesthetic is informed, and he cleared the patient and he checked all the result investigations are there, and if the once the patient will come, you would like to do urine pregnancy test for all the reproductive age group patients. You generally said it all the points so that you don't have to say with every patient. And you said that you will see that if they are still on medication, mention some of the medication like OC, OCPs and HRT need to be stopped 4 weeks if she's still smoking or not, and you will see if she's on any aspirin or blood thinners. Mention some of the medications. So, and you will see if PTE risk assessment is done or not. Enhanced recovery program is in place, and you mentioned enhanced recovery program you should mention in every surgical case and WHO checklist. So the first patient you said you said about the risk, and there's one thing you could have done a dye test. She's a case of infertility. There is infertility written for some reason. So you should have done the dye test at the same time. And you want to know that, yeah, the, the risk is BMI is 18, and she might be having endometriosis and adhesions, uh, and some endometriotic uh, spots that need to be ablated or excised. So, so these are the risks. You offered this one. You suggested the PowerPoint, which is fine. PowerPoint is fine. And what you are going to do in a stage, but you want to make sure if the consent is there for the treatment for endometriosis. So you are just making sure that if the consent is there, and because you have to say that there is a risk of injury of aorta. You have to mention the vessel name. Yeah, that's why. So generally speaking, whenever you say something justified, this is the only thing which I noticed. Uh, and I'm sure that you will practice. You still have some time and you are doing very well. Just you justify the things, whatever you are saying. You know why you are doing it, but you have to say it. The second is she's obese. Yes, she's a big fibroid. So you want to show, and she's 48 years old. So she might be having medical comorbidities, which you want to make sure, and obese, infection risk, wound adhesions, risk of bleeding, all of these things are there. And the question of removing the ovaries, uh, you have to say that I'll make sure that if she consented for removal of ovaries, and why they decide for removal of ovaries if there is a consent, like she has family history or if she has any ovarian pathology on ultrasound, because if the surgical menopause and the risk of using needing HRT is written in her informed consent or not, she knows about it or not, that she will be most probably might need HRT. So if there's she has no family history and if there is no ovarian pathology, then we might not do it. So once the patient will come, you will talk to the patient again. Okay, depending upon the consent. So you will check the consent of the patient, and then if it is written like this in the consent, then you will, when she will come, you will again talk to the patient, So all you said all the things, precautions for this BMI and GnRH agonist, which is good. Evacuation, yes, she needs antenatal.
Ma'am, one question. You asked about the vertical incision.
Yes,
What precaution? I mean,
yeah,
uh,
it means if you are giving a vertical incision to an obese patient with BMI 38, Yeah. It means that if the fat pad is more than 2 centimeter, you need to stitch that subcuticular fat
Oh,
and
okay.
mass closure.
Okay. Okay.
Most probably with PDF. This is
Okay.
what we are doing. Yeah.
Okay.
So are you using Proline?
Yes, we use for rectus sheath, we use Proline.
Mm-hmm. Okay.
Loop Proline we use for vertical suture.
Hmm. You don't use any other suture?
PDS is very costly, so
Oh, that's
mm,
why, because we were
that's
always
why.
using PDS sutures, the
Yeah,
looped one.
only because it is costly and because it's a
Oh,
medical
okay,
college.
okay.
So
Because other candidate also talked about proline.
okay.
Um, so I was wondering why people are talking about proline. So this is because of the cost. Okay.
Cost, yeah, because it's a cost.
Okay, but both of the things are fine and you can mention. There is no problem. Okay, so molar pregnancy and uterine size is okay. She's RH negative. So there are some risk factors of bleeding, and she needs NTD, and she needs, as you said, ultrasound guided. A senior person should do it, and if she start to bleeding, we need to. It is written in the guideline to expedite,
Expedite, yeah.
and then if she's still bleeding, then you can give oxytocin. So yeah, and you are right. Register her. She should be followed up for the histopathology needs to be followed up to see if it is a complete humoral or if it is complete, that if she's having any signs of
New place.
any persistent neoplasia, yeah, trophoblastic disease. So this one, I prompted you. Then you said that yes, I might need to see if it's a simple cyst, and if CA-125 is 12. So, and if she's not symptomatic, so we will see if we really need to do it or not. So, but if it is written uh, in her file that it is decided already by the consultant and it is agreed by the patient, and maybe she's symptomatic or whatever the reason they want to do it, then these are the precautions that you need to take. She's previous one cesarean section, so she has a risk factor. So you already talked about alternative techniques, what you will do. Yeah, that is fine. You prioritize according to the bleeding and according to the day case or not day case. And there's one thing more, that if any of the patient is having serology positive for HIV, for example, or hepatitis B, then also needs to be the last one in the list. Yeah,
Okay.
for the infection control point of view. But this is not the case over here. So most of the things you said, hmm, so it's a passing station for you too. So let's see. Usually in gynae ward prioritization, they will give you 3 to 4 cases, and you need to prioritize them, that this is the first, second, third, and you will need to gather information about them. Maybe you need to know a little bit more about them from their case notes, and then you prepare them for surgery. And also you will talk about intra-op management.
Okay.
So not more than this, that's it. So first case is in the list. She has what you call it, which one was the first case?
Vesicular molar pregnancy.
But I think I go one by one. The one with the
Oh, okay,
BMI
okay.
was
Yeah, yeah,
high.
yeah.
Yeah.
Yeah,
So
the lean patient, the young patient, infertility, chronic pelvic
yeah,
pain.
she was the first one, but I don't know why I start talking about this one, but it's okay. The obese one. So you will see if the consent is valid or not, result of recent blood workup, pregnancy test, which you said together, all together in the beginning, which I like. So seen by anesthetic or not, any comorbidity because she is 48 years old, multidisciplinary team members, if she is having any comorbidity, and if her hemoglobin is optimized, blood group and save is there, because she has bleeding tendency, you want to make sure that blood group and save is there, and if she has any reservation for blood transfusion. Although this is set for pregnant lady, but because she has risk of bleeding, then it's okay to mention. VTA risk assessment, she will need prophylactic thromboprophylaxis, like stockings maybe, and later on continue the stockings, but maybe she will need prophylactic other kind of, so just we can say that we will see if she will need prophylactic thromboprophylaxis before the surgery, and recommend prophylactic antibiotics to be given before skin incision. You might need an extra assistant to hold the abdomen, and midline incision mass closure might be needed. You talked about GNRH already. Did you talk about informing the blood bank?
No.
Informed consent is needed for oophorectomy, and if no consent, then you will say that I'll not remove the ovaries. It's a source of androgens. If you remove ovaries, check in the consent if HRT is discussed with her or not. So evacuation of molar pregnancy, she can bleed. You have to do blood group and save for her. If blood is available, consent is ready and valid. Make sure if she has any patient who is going to bleed, you want to say the same things, blood bank informed or not, any reservation for blood transfusion, group and save. Okay, what's her hemoglobin? The last hemoglobin. Intraoperatively, she should have IV cannula. This patient should have IV cannula because she has risk of bleeding, use of suction curettage, and under ultrasound guidance. Under ultrasound guidance. I don't know, I mentioned if needs to be done by senior. Ultrasound guidance. Yeah, senior person should be assigned. Expedite the process if she start to bleed, and once uterus is empty, you can give oxytocin. If still bleeding, you can, if you want to continue, that if she's still bleeding, you can call intervention radiologist to embolize uterine artery embolization. Third case in the list is the laparoscopy. The first one, I think I bring it here. If she's young, there is no age written for her. You can check from her file, from her case notes, and you want to see if the result of investigations are there. But is this patient that you were talking about? There is the infertility. You were talking in detail about her infertility, isn't it?
Um, yeah, if she has endometriotic deposits and ablation, because a question was written.
Hmm. Um, you know, there is no need to talk about her infertility. And yeah, sorry, you were talking about her, all the, yes, now I remember. You were talking about all the things which are given in the consent guideline.
Oh, yeah.
Yeah. So no, she already has a consent by the consultant. You only need to see if the consent is still valid or if she developed any other complaint after taking the consent, or if she is still want to do the surgery, because here in elective cases they take consent long time back, and but you still want to see that if the consent is valid, or maybe she developed any other problem, or maybe she changed her mind. So just you want to check the validity of the consent. You will not go through all the points of the consent. No, there is no need actually. So seen by the consultant, BMI is low, surgeon might need PowerPoint, avoid aortic injury. You need to mention this name, aorta. Endometriosis suspected, so adherolysis may be needed, ablation spots. If informed consent is taken from the patient or not, you have to make sure. And if it is not taken, then when the patient will come, it is better to talk about it before going for surgery. That if there are two possibilities, maybe you don't find anything, she needs to know also, as you said, or maybe maybe you find adherolysis. So there should be a consent, because you cannot do it unless there is a consent. dye test, mention about dye test and tell her that uh, we might need to do a dye test. Actually, we will do a dye test. So together in the consent form needs to be written. Uh, the last patient, you want to make sure if she's symptomatic or not, or if this is an incidental finding, this ovarian cyst, or if we can postpone the surgery for her. She's previous one, so open technique is good for her, or even PowerPoint is appropriate. Conversion to laparotomy for all laparoscopy patient, you need to see that if in the consent conversion to laparotomy is discussed with her or not. And if she signed the consent is still valid, seen by an anesthetic, result investigations are ready, and all young patients, whenever they admit, you have to repeat the pregnancy test for them. You need to inform, this is in the beginning, you will say, I will inform or the theater staff that the patient is admitted. I will inform my consultant that all the patients came, and I will inform the blood bank if there's a risk of bleeding, for example, and I will check the result of investigation. I will inform the anesthesia. This is what you are doing exactly when you're on call at night. So you will say the same thing.
Okay.
Yeah, okay. I think this is also a passing station for you. So generally speaking, just justify. This is the only thing I will say. But passing mark is not 100%. If you say like more than 70% of the things, I'm happy. And the chances of passing are, but I want all my students to say 80% of things or more, and you said more than 80% of the things. So this is according to the recommendation. I don't have any more thing for feedback more than this, because you did well. And good luck. The
Thank you
last
so much,
but
madam.
not the least, good luck.
Yeah, thank you so much for the session. It was so
Yeah,
nice.
you like
Yeah,
it?
thank you for,
Thank you,
yeah,
well.
it was so nice. Yeah, the
Mhm.
feedback was very good, madam.
Yeah, so
I like it.
please tell me about your result. Don't
Yeah,
forget me.
yeah, sure, sure. Yeah,
Okay,
sure, I will
I'm going
definitely
to
tell you.
stop the recording.